Welcome to day 4. So we're here in the operating room. Maria is putting Caroline Falabi, a 51-year-old lady with a dissection to sleep right now. We have Professor Andy Owens, who's come over, a specialist aortic surgeon. He's going to be doing some of these very difficult cases today. We've got Kim with the perfusionist setting everything up for this advanced case, and we've got Jill with the theatre staff just prepping everything outside. So it's all really kicking off. We're actually going to see if we can do 2 cases today, so it's not even 9 o'clock and we're in here, which is a really great start. So it's going to be a really busy day, and we found another thoracic case, so let's hope that goes ahead too. So let's go to the intensive care, see how yesterday's patients have got on, and then we'll get started with the day. How are you feeling today? Yeah? Feeling some pain. Nice to be the other side of it, isn't it?
Yes.
Or finish, that's nice, isn't it?
Thank you.
Great, yeah, great. Alright, good to see you. We'll see you a little bit later.
Alright.
That'll be great. Well done.
Thank you.
Hello.
Yeah.
Yes, you're getting up. That's good to see you.
Yeah.
Yes, good to see you. Yes, good to see you getting up. Don't let me stop you. You've got to get up. The more the better, isn't it, to get up and about. Good to see you looking well.
Why are you pregnant?
That's good. A lady from yesterday. Hello. Are you feeling well? Yes, the operation went very well yesterday. Very happy. So yes, hopefully you will recover quickly. Let's hope. But yes, nice to be the other side of it, isn't it? Yeah. Great. Well done. You're doing great.
So, Charlie, who knows the story? Who knows the patient? Tell us the story a little bit, just to remind ourselves.
She's 51 years. She's hypertensive. Had a previous history of cerebral infarct. It's a chronic cerebral infarct.
How long ago?
Otherwise, 4 years ago, she's been otherwise well until almost 3 months ago when she had sudden onset of central chest pain. She said she felt like dying, became diaphoretic. I was sent. She works as a caterer in the psychiatric hospital. Was initially sent there, and then later brought to UGMC. She came with a very high blood pressure.
It's not. You just keep saying that.
See, that's what worries me. There's clot all over the place.
So, I've pounded it off already twice. I've done surface once.
That looks like a true lumen there. There's a tiny one, doesn't it?
Yeah, we'll do that. Maybe have to reboost it. Or maybe it's just that there's no.
That's the corridor there.
Yeah, so that's a true lumen. Yeah, decent. It's not too big a sinus. There's your flap coming up. So true lumen, true lumen, true lumen, true lumen, true lumen. So I'm going to try and cannulate there. Otherwise we'll get, because auxiliary is going to be tedious because she's so big, getting into her, so it'll be a nightmare. Okay. Yay.
Have you got the echo?
No.
We're ready. We're just messing about until you're ready. Okay, you are.
How's perfusion, Kim, for the big case?
Better.
Better than off pump.
We've made some slight changes to the perfusion circuit, which will make life a bit easier, certainly with the plegia delivery. And so we'll see how it goes today, and I'm sure tomorrow we'll change something else. You know, that's how it works.
Yeah. Who have we got here? We've got Dan with crew. Dan, Bill, Silas, Benat. Good to see perfusion team working hard. Good to see you guys. Hopefully it'll be good. Good stuff.
Were you doing the time out?
We're going to do a median sternotomy and we're going to evaluate her aortic arch. We'll cannulate probably for a nominate using a side fiber and a little graft. If we can't access it, there's a slim chance we'll use femoral. Then we will go on bypass, cool to 28. We'll stop the heart initially with retrograde cardioplegia, and we'll open the aorta, resuspend the valve, put in a tube graft, take out some clot, and maybe deploy a stent in her arch and descending aorta.
Are there any specific requirements, special investigation?
No, Natasha's up to speed with everything we need.
Are there any unexpected steps that the team needs to know?
Nope.
Happy to carry on?
Very happy.
Okay.
Yeah, let's go on the music and let's get going. Okay, so let's see. So there's an nominate vein appearing with two black and blue in here. Oh, there we go. Ding.
Can I test my second? Can I test the second?
Stretched over her aneurysmal. So we've got, well, this is as good as it gets. This is as good. But you can see how dry it is just by avoiding heparin and fluoride. We've done a ton of work. We've done a ton of work here. So that's half the operation done. Mobilised your vein, mobilised your arch. On bypass, we'll take that sticky stuff. Doesn't need to be done. So
You see,
we can do
that
that.
is your valve. Okay, I'm starting heparin.
Yep. So I'm clamping the anominate area. Okay, knife please. Yes, hang on to that there, hang on at all. Just kidding myself that I'm doing a bit. I'll cut rubber shot in the end, thank you.
Give me that first.
Looking good. It's not a vessel that's meant to have anything done to it because it's got no way. Okay, a couple of times. Happy? Feel free to ask anything at any stage, don't worry.
Very tight.
Yeah, it needs to do two. Sure, babe. Awesome. Through to you. Okay, let's push on this through here.
Go.
Hang on a sec. So again, classic aneurysm.
The IVC is shifted.
Yes, I'll shoot them There we go. Super. Just like
That
this.
is the venous cannula.
I'll fix it later. No, someone earlier. There we go. That's the one. Thanks. Stamps are off. Go on bypass, please. Cool to 28. Okay, so retrograde. So some people put it in there.
Yeah, that's.
And the reason they put it there is that the coronary sinus is directly below it. So the way to picture it is imagine you're in a posh hotel and you're in a wet room. So you've got a fancy shower, and the shower tray is the fossa ovalis, and in that far corner, that's the coronary sinus, and it's going vertically down. So when you go in with this cannula, this is bent. Well, it's a little bit bent, so it's bent the right way. So basically, this handle is key. So you go in through the hole, turn it all around so it's pointing down, and then you're just feeling like with your toe, you're feeling through the plug hole. So all you're doing is dab, 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 dab until you feel it go into something. and then it's advancing over the true car. But people go in and they start doing that and all sorts of shit. No. So this is your toe, and you're trying to find the plug in the shower because you've dropped your contacts. Thank you. Okay, so it doesn't matter what way it looks when it goes in. Turn around. Let go. Thank you. Picture you're in the shower. We're going to try and find blood flow in the shower. Now, this is going to be difficult because she's small and it's all distorted. And that's in.
They're in.
Yep. Snug, please. Okay. It's on. Clamps on, I think. Back up. Thank you. Run your page, please. It's retrograde, thanks. It's working. Okay, dissection scissors, please. Let's open this aorta, see what's going on. There's a floppy sucker there. There's another lumen, that's the true lumen. Right, dissection scissor, please. Yeah, chop it off, as they say in the trade. Already what it's telling me is that there's going to be quite a curve in the graph that we put in, so I'm already thinking about the length of that. So we just need to be careful, we can very easily go into PA right here. Yeah, right, especially this one which is welded onto this aorta. We do have to go in here, so let's just keep working our way down.
Is it alright?
Yeah, I've seen that. I mean, sometimes it's going to happen anyway because just where it's area.
Just close to it.
Yeah. Okay. Right. Over here. So what? Okay. Let's immobilise some more tissue. So it is. We've got an aneurysmal ascending. Maybe not really an aneurysmal. Let's go into the tear. So the only thing I'm looking at is the commissures and the coronaries. It's the only thing that interests me now. Everything else is irrelevant.
Okay.
Just here. Because all I'm thinking about is right, what height. So and then checking my coronaries are. Can I go a second there? It's not going right. Sometimes you can have a height. No, they're the rights. Oh, it's exactly the same level as the commissure, so that's fine. Alright, that's that one far enough. Oopsie. Sorry, Natasha, I'm very bad at that. Thank you. Okay, let's go around the right now. So go right to there, get the same sort of height.
Well, you go very low, don't you? Are you going to do reach?
No.
No. Bloody hell.
That's not low. Hang on. That's the depth above the. If you don't go that low, you end up leaving abnormal tissue, which is going to get you into all sorts of trouble. I'm going to do this 2 at a time, or 1 at a time. Sorry.
Smokerini, that is low.
No, it's normal. Sorry.
I was getting prepared and I asked you if you're going to prepare.
Okay. Right, let's fix this valve now. 4-0 please. Pledge it. You see, if they were saying I've gone too low, well, here's the thing, if you don't put these prejudice stitches in the right spot, they're not going to re-suspend your valve, so you have to go down to this level to get your valve re-suspended appropriately. Hang on a second, right there. That's the one. Okay, and that can come off there. Let's see. Oh, I hadn't patched it. Okay, restart your circulation, please. Antigrade, non-selective. Thank you. And let's have a look in. Have we got another floppy socket now?
You use a retrograde to occlude the subclavian.
Yep. Okay. It's never in the true car, this one. It comes that way, unfortunately. Okay, you can see why this is funny. So that's in the subclavian. And so we'll see if that pressure comes up. Okay. The second scissors, please. So the clot is really well organised, which is a bit of a pain. I suppose that there's pros and cons to an AMDS in this situation, isn't there? You know, what do you think? I genuinely don't know the answer.
I generally don't know either. I mean, feels like, I mean, you're definitely not using it to, your disc mass are doing fine in terms of reconstructing and doing it.
We just leave it.
Yeah.
I'm tempted to not use it.
I'm tempted to not use it.
You
You might create more problems than
the
you...
clot's really solid.
You might create
I
more
mean, if you use
problems
it
than you
potentially
solve.
tomorrow when we size up the guy tomorrow, well, that's PM, I've got to chop into. You know what I mean? It's PA's okay, let's just go in there. That'll just stay behind, that's fine. Yeah, no, I'm inclined to agree. I think that's a real thing. Okay, let's go down here. That's the clot. That layer there is clot, I think.
This is the
That's
inner
clot.
This is the clot that has become.
That's a fake layer.
Okay.
Yeah, so what I'm thinking is that the AMDS stent may get compressed. So I don't think it's going to help. So I think what we'll just do is we'll just do the normal dissection operation. If you know what I mean?
Yeah.
So, because what we don't want is that stent gets compressed, it'll cause more problems than it's solving, I fear. Because we're not dealing with super fragile tissues, we're dealing with rubbish tissues, admittedly, but not super fragile ones. Okay, can we have 2 strips of Teflon, please? Alright, so what we need to do is just get started on this anastomosis. Yeah. Okay, 4-0 please. Okay, so yes, Bob, you're right, get on and sew it, Owens. I was internally wagging my hand at myself too. I'm just making a meal of this anastomosis. Still thinking about breakfast. If you need lots of little bites, what you don't want to do is constrict this down any further than it already is. So, unfortunately, relax, thanks. Like relax the suture. It doesn't. So you don't. You know, you can. You don't need tension in this one. Yeah, okay. Yeah, but you'll also first string it. So this one's all about lots of neat little bites. Because all you're thinking about is, I got to get my layers together and give me something fantastic to sew to. So these ones you want to start getting really deep and really meticulous, because this is what's going to close our false lumen. Come on, you can go in. So what we're trying to do is not have ruffled up bits where the blood can get in.
Can we come out the way?
Oh yeah, sure. Yeah, we're going to use up a lot of the pulse in some of these bites. I'll take some extra ones to get rid of it actually. It's just the thickness of it. I'm going to have to look at my spacing a bit more critically now. That's where I want to be, there. Yep. Just push the vein back, could you? And push the vein back. Thanks. I don't go through it again, which would be really embarrassing. There we go. Okay, we'll take the tube graft next and the 3-0 proline, please. Beautiful. So.
The subclavian is bleeding that much?
Yeah, it's good, isn't it?
Good.
That's great news. I mean, that's what we want. It means it's working. So it means our flow is okay. Well, it means it's working. It feels okay as such. Okay. Any other sucker? Is that one? Thanks, Gordon. Okay, this is big for her. I mean, it's the 26 at the beginning, but this is what it is. Is that a 3-0? Yeah. Yes. Lovely, thank you. And forceps, please, and then rubber shod to Gian. Let's see, where's halfway? Right there, okay, keep it there, please. Yes, right there, right. Lovely, thank you. Okay, just think this through. It's always a bit awkward doing this with the tubes in, but it's worth it. 3-0 seems big for this, but you're putting it through so much Teflon and stuff that a 4-0 needle will be dead very quickly. Okay, so now we just do that, like work my way around. Yeah, I'll just do a couple of bites, then we'll flip them to the other side, and then it'll look lovely or less ugly. Okay, follow up to the left there, please. Yeah, don't worry about that, just follow that way. That's cool. Perfect, thank you.
So do something with it. I don't need it.
sure?
I will need it unless you have similar.
Nah, I'll be fine. I'm not going to go deep. There you go. We just rotate. So we need to rotate. So we let it rotate around with us, and it follows you. So you do this technique. You just bring it around towards yourself. You get to see, every bite you can see, especially at the vulnerable point of the heel. The other trick is make sure it's inverting all the way around as well. It's causing a static. So we've got a lot of tube graft to use up, obviously, because it's so much bigger than our aorta. So we're just going to need to think about that at this point. So small bites on the graft or big bites on the graft, sorry, and small bites on the aorta. It's fine. Just going to take a couple of really big ones here, except we're going to have to stitch them at the end. Yeah, we're just going to have to put a couple of enormous pages of stitches here at some point, which is fine again because this is the. In fact, there may be merit in doing it before you take the clamp off, but this is where the false lumen is. I mean, this graft is just way too big.
Get some sutures.
I think we just see what it's like, because you just don't know until you feel it. I think at the end of the day, we must have shut. We're not going to get any better shutting out the false lumen. We've really put a ton of effort into that, so it is what it is. Yeah. Cheers. Okay. Could we have the small fogarty cross clamp again, please? That's the one, thank you. Right, flows down please.
Flow down.
Thank you. Squeeze out your hand so it doesn't all come pouring out. Back up please.
Flow back up.
Back up to full flow, rewarm, you've got full circulation now. Thank you.
Thank you.
Cool.
It's not bad.
I'll take that.
Yeah.
Is that the best you ever get from him? Not bad.
No,
Thanks. Raffo says it's not bad, so that's all right. Okay, same again. Have a strip of Teflon, please.
Obviously separating with different pledges, but I mean I can see the advantage of going low because you've got much nicer tissue, isn't it?
Yeah, well that's it. For me it's all getting down. It's also you've got to get below the tear, and the tear was down to, you can see the edge of the tear is there. So that's a little bit of heel, so I just want to get beyond the tear and I want to get beyond that false lumen. Thanks Natasha, you've given me move faster. Everyone clearly wants to help you do a goring double valve. I used to try and get away with one layer in this, and I've stopped now because I'm rewarming. I've got the time to put, put the two in. Yeah, it's just not worth the pain. The start of that false lumen. I want to get this completely eliminated too. Not blocking. Into two needles. Well done. Shut that up as well. Get it from this side. It's not bad actually. That'll be fine. Just need to go see where it sits. That's fine. It's just the angle's the only issue. Oh my golly gosh. Right, heavy straight scissors please. Thank you. I mean, we're going to have so much graft left over at the top there. It's going to be very interesting, but you know, it's what it is. It's what we've got to use. It's what we're going to use. No, that's fine. I'm going below.
Okay.
So I'm working away. I'm going to do the same again. So yeah, so this anastomotic technique is great. A mate of mine taught it to me, and you basically work your way towards the heel. That's how I do the buttons as well, and the coronaries. But it's got potential for serious tangling initially until you get it going. Just 1 second. There we go. That's good. Okay. So you see how much graft I've included in there, folded it in, yeah, because it can concertina. It just feels weird doing. but it kind of, you know, it sits where it needs to sit. Sitting there, probably just getting away, won't it? So I could have used a 3-0 for this, but...
What number is it? 3-0 or 4?
What's that?
What's that?
3? Alright, there you go. But 3-0 I have at home, it's got a slightly bigger needle, which is makes it a bit easier. So now I'm going to start coming out. Yep. Oops, well, not the hat. So every so often, just take a little breather, go, hang on, right, see how we're sitting. So you do that, and you go, okay, suddenly it's just a bit more relaxed, because you look at, see how much, thank you, see how much graft we've got, and you're like, oh, okay, that's going to work, you know. So even though it looks a bit scary on the way, if you've lined up your top side, it'll work. But yeah, you need the top to be sort of tight, and all this, you know, so you guys should be doing this every day, mate. It's not difficult surgery at the end of the day. It's just diddly surgery. Horrible graft. I think we're agreed that there's nothing easy about this one's arterial lines. You certainly made it look that way.
Oh, it wasn't.
Vent off, please.
Okay.
That's the red off, thank you.
Yeah.
Just start de-airing slowly, you know, why not?
Done, we're almost done.
Yeah.
All those who said we will not finish today, we are done.
Well, it's not over yet. It's not over yet, guys. It's all matter of hemostasis and recovery from the anaesthetic, you know. Thank you. Vent back off, please. Red off. Thanks, Dan. Sorry. Yeah.
Yes, you got the devil ACT.
Especially when Dan in charge. Creature background. Have we got a needle we can de-air with a Medicut or something? Yeah, cheers. Right, bit of volume please, 2 puffs in the lung, de-airing, vents off, yeah. Alright, flows down, take your volume back, thanks, stop ventilating.
Empty out.
Thank you. Cross clamps off, back up please.
Thank you. Thumbs up?
Yeah.
Yeah, thumbs up.
Can I take my CVP back?
Yes, thank you. Yep. Perfect. Room for more. Yeah. Getting there. It's better than the last time.
So maybe just tell us how the case went. Quite a big case.
It was a big case, yeah. It was a predictably big case. As you know, it's a lady with a chronic aortic dissection, which is an uncommon and difficult thing to fix. The scrub team are fantastic. It's really good to see how much they've progressed in the last few years. So that was super. So we cannulated the innominate with a small graft, went on to bypass, cooled down to 28 degrees, resuspended her aortic valve, and then moved on to the aorta, got rid of the tear. There was a huge tear in the ascending aorta, so that was really good that we got rid of that, and put a tube graft in between, and we've put it all together again. As we expected, we had a coagulopathy at the end, so controlling the bleeding hasn't been much fun, but it's been predictably challenging, so that's okay, no surprises there. So we've just closed up. We're really happy with hemodynamics, not requiring any support. Kept the patient warm, which was good. So yeah, let's see how she goes. There's a decent chance we're going to have problematic bleeding overnight, but that's typical of aortic surgery. Let's see what the evening brings.
And let's see what tomorrow brings.
Tomorrow's case. Yes, tomorrow we've got another very complex case. Joel's laughing as he's talking to me here. So it's another chronic aortic dissection, this time with severe aortic regurgitation and some of Marfan syndrome. So that's going to be a big case. So this was a lovely dry run. There really is so much aortic surgery over here and so many aortic dissections. It's been great to take the surgical team through some of the tricks we've got in aortic surgery, some of the techniques we've got, so they can handle them more themselves, and I'm sure they'll do a great job going forward. But I think tomorrow's my problem.
Excellent. Well, I hope you get some rest, and yeah, well done today. A big case, really well done.
Yeah,
good
thanks
job.
so much. Cheers. Bye.
Good job. So that's the end of day 4. Big case, gone really well in the end, and so well done Andy Owens and well done the team. Big long day, and back for more tomorrow.